Now I'd like to invite our next speaker, Dr.Suganthi S. Nam, Assistant Professor in Department of Pharmacology, JIPMER, Puducherry. Her field of interest en- encompasses oncopharmacology, clinical pharmacology and toxicology, regulatory pharmacology. Ma'am will be presenting on designing clinical trial, binding, randomization, and allocation concealment.
Thank you. Thank you for the kind introduction. So let us start with our next session. So we had a wonderful session on how to frame your objectives. And in the clinical trial, another vital thing on everybody should learn is the study design aspect is the randomization, allocation, concealment, and blinding. So we will, I have outlined this will be the outline of my presentation for the next half an hour at the max 40 minutes. So what is this randomization procedure? Why we need this procedure? And what are the different methods that are existing to generate a sequence? And what is this allocation concealment? What is the purpose of it and how to do? And we will cover blinding and who all can be blinded, how to, and at the end, we will see what are the reporting guidelines available. How will you write it in your scientific paper? So this will be the brief outline for my session. And I think since yesterday, you all have been learning about this. So RCT stands for, the name itself says randomized controlled trial. So it is not, C denotes controlled rather than many people assume it as clinical. So of course it is a clinical research, but component of clinical research, but it is a randomized controlled trial. So if you take any trial, how it differs from your observational studies, RCT, you have a target population and the investigator assigns the exposure. Here the exposure doesn't happen on its own. The investigator assigns an exposure to a participant, either to control arm or the new intervention arm, treatment arm. So we commonly label it as control arm, treatment arm. And finally, you follow up the patient for a certain period of time for the final outcome. And we will do an analysis. So I think, I hope analysis will be covered subsequently in later sessions. So you have a target population and how these participants are being assigned. The process that helps in assigning participants to either control arm or treatment arm, wherein comes your randomization. Okay, so let's go in depth. So what exactly it means? When I say randomization, it means the process of allocation of participants in such a way each participant has equal chance of being allocated to one of the treatment groups, either of the arms. So here the 50%, the participants have 50% probability of enter into either of the arms. So that is the definition for randomization. And this is the experimental design randomization developed by none other than the Doyen Ronald Fisher during early 19th century. And it is implemented by Sir Bradford Austin Hill in the clinical trials in human clinical research in 1940s when this clinical trials started flourishing. So this was implemented by Austin Hill. So, you have a target population which comprises of different representative. Just now I heard in your previous session, beautifully it was covered representativeness of the target population. So if you have intervention for a hypertension, so your target population should be, and you have a set goal, whether you are targeting severe hypertension or mild hypertension. So you have a target population. With the procedure, randomization procedure, you have no control over you have no control of choosing a patient to either arm. So the randomization procedure will take care of it. So every participant has 50% probability, equal chance of going into either of the arm. So it can be in statistical textbooks can usually find a common analogy where even a couple has 3 boys. What is the probability of having a boy or girl in the subsequent birth? So it will be kind of random. It has 50% probability. The same will not be said for some X-linked or some dominant, autosomal dominant or recessive traits. Okay, so that is not a random occurrence, but the gender assignment is totally random for every childbirth. So that's a random event. Okay. So why we need this randomization? What are we achieving by doing this randomization? So why can't we simply assign whoever to my whims and fancies, why can't we assign a participant to a certain treatment? So as you know, by this time, you will have a properly framed research question and you have a study protocol. You have your inclusion, exclusion criteria at hand. You have a screening. So inclusion, exclusion criteria will determine your screening form where you will look for participants' eligibility. So once the participant is eligible, you will get the consent and you will enroll the participant in the trial. Now he has to be started on a particular treatment. He have to assign a particular treatment to the patient. So exactly how will we do? So what kind of biases that can occur? So I would like to highlight an example. So this is a study published recently in February in Lancet Infectious Diseases on the real world use of Paxlovid. It's nothing but ritonavir boosted nirmatrelvir for outpatients with COVID-19. As you can see, I am highlighting here, it's not an RCT, it's a cohort study. I would like to highlight a particular survival curve which they have presented in the paper. So can anybody comment in the chat box? What is the problem with this figure? Is it okay? Or do you agree with the findings? As you can see, this is the all-cause hospital. This is the cumulative incidence plot of all-cause hospitalization to day 28 by treatment status. So the red line denotes untreated patients. The blue line denotes who got treatment with nirmatrelvir ritonavir. Can I see some response in the chat box? Anybody? So do you agree with the finding that they have found the treated patients have low incidence of all-cause hospitalization compared to the untreated group? Okay, if I would like you to concentrate on the beginning of the trial. As you can see, the two groups widely separate. In RCTs, you could have seen the baseline should be exactly similar. Baseline is usually comparable between both the groups. But when you do observation studies, lot of selection biases happen, how the participants are being enrolled. As you can see in this figure, at the first dose itself, the groups are different. Number at risk, somebody is typing the answer, I guess. So as you can see, so this was a lot of trolls have been made in the Twitter, and one of the famous epidemiologist and hemato-oncologist I quote him, shows great study, shows Paxlovid works even before you take the first pill. It's just an exaggerated way of saying, but simply it is a case of observation study. You have to be very cautious in interpreting the results. The point I want to make here is the selection of patients during observation studies. If you do not do randomization properly in the controlled prospective studies, or prospective cohort study or prospective randomized control trial, if you do not do selection of participants at random, without randomization, if you do, you end up exaggerating the treatment effects without actual evidence for it. Okay, so that's the point I want to make. So the baseline should be comparable. Here the selection bias has occurred. Probably it could be n number of reasons. They were the participants who are enrolled in the trial was, I'm just hypothetically guessing, could be affordable, or they were already cautious in wearing mask, going to social places. They would have, there will be n number of different characteristics would be different. It may not be due to the nirmatrelvir ritonavir treatment. It could be the treatment effect you are seeing here could be because of other factors rather than the intervention. So you eliminate, when you do randomization, you eliminate such potential bias in treatment allocation. So you avoid selection bias by doing the randomization procedure, because you give equal chance for every participant to go into either of the arm, rather than you dictate which patient to go for which arm. The other thing you are going to do with the randomization procedure is you are going to achieve balance with respect to known as well as unknown risk factors. So many a times you must be knowing the prognostic factor. For example, mortality for a trial that has mortality as the endpoint, you already know age is definitely going to play a role. When you have more number of elder patients in one group, definitely the mortality will be highly likely in that particular group. So you want to achieve balance. So the age above 65 should be balanced between both the groups. So that you have to, so randomization will help you achieve the balance between known risk factors as well as which you do not know. Their diet pattern, there might lot of omic studies are taken care of happening, and lot of microbiome, genomics, everything we cannot be accounted for in a trial. But randomization, by doing a simple and effective randomization, you are balancing both known as well as unknown risk factors. And it also enables you to apply all your formal statistical inferential tests, inferential test validity will be maintained when randomization is applied. Now, another advantage of doing randomization is it facilitates the blinding procedure. We will see what is blinding in subsequent slides, but it will facilitate your blinding procedure, since I will come back to this point again. I'll emphasize this point again when we discuss blinding. So to help identity to help the identity of the treatment, maintain the identity of the treatments. So these are the purposes of doing randomization. It eliminates the bias. It achieves balance between known as well as unknown risk factors. It enables the valid application of your statistical inferential testing, and it facilitates the blinding procedure as well when you do randomization. So thus, since it eliminates two important biases that happens in the clinical research. One is selection bias. So the knowledge of, in researcher who might be enthusiastic in showing a positive result in an experimental group might subconsciously, if the selection is left to him or her, they may subconsciously choose a younger population or patients with good prognosis to enter into the trial. Or similarly, the confounding like age or disease severity. So oncology trials, this often happens, the stage of the disease. So stage of the disease matters for the prognosis. So you enroll for novel therapy, milder disease patients, or stage lower stages 1 and 2, and for standard therapy you keep stage 3 and 4. Ultimately, what you will see, the exaggerated treatment benefits with the intervention arm. So when you do proper randomization, you eliminate selection bias and confounding bias. So I hope bias would have been already covered. Bias is nothing but it's a systematic deviation from the truth because of error, because of any error. Okay, so that is the bias. So here selection bias, how you select the participants for the trial, how you assign a treatment to a participant, that is selection bias. The confounding bias is the balance of prognostic factors between both the groups. So since randomization eliminates these two biases, thus it is sitting at the top of your evidence pyramid. So in the hierarchy of evidences, the RCTs and pooled analysis, meta-analysis and RCT, so they occupy the higher position in the evidence pyramid, mainly because these biases are overcome with doing randomization. So randomization, when I say, it involves two steps. The first is generation of a random sequence, and the second is allocation concealment. So random sequence generation plus allocation concealment together completes the randomization process. Okay, simply without allocation concealment, random sequence generation alone doesn't qualify to be a true randomization procedure. Please make note of it. We will see how we will do one by one. So first we will see random sequence generation. So can somebody respond in the chat box? Can we assign a particular some patient by his date of birth. Like if a person comes with odd number or even number, odd day, we can give can we consider these as random? Date of presentation to your OPD or alternate assignment. First patient I will give treatment A, second patient I will give alternately, I will give AV. So is this considered to be a random assignment? Anybody wants to weigh in? Yeah, I could see. Can somebody explain why you don't consider these as random? Yes, everybody agreed it is no. Yeah, I also agree. Can you say why? So, shall I wait for some time? Okay. Why these are not considered? They are systematic way of doing things, and in any of the nowadays this have come down significantly. But in many of the older version, even though the studies reports as random assignment, but they have used one of these three techniques. So these are systematic way of assigning a participant, but they are not strictly considered as random, because when you know the by date of birth, you already have the patient record, you cannot practically do allocation concealment. You already have the prior knowledge of who is the participant is. So intentionally or unintentionally, you can have selection bias when you use one of these techniques. Even though many papers write this as random, they are not strictly random, and you cannot practically do allocation concealment if you do it in this way. So kindly avoid doing such technique. These are not considered as random. So how to do methods of randomization? Let us see. So we have two broad methods. One is simple randomization, also known as unrestricted, and you have restricted randomization. So restriction randomization, you are going to do it to balance the sample size in each group. When you have two arms, you are going to assign them to drug A versus drug B. You want equal number of participants in each group. To balance the sample size, you will go for either block randomization, and there is another adaptive type of randomization called biased coin or earned randomization. If you want to balance between prognostic factors between both the groups, if you have a strong risk factor and you want to beforehand want equal number of participants in each, let's say for some CKD or hormonal status on a female. So in that case, you have two different types, that is covariate adaptive or minimization. Sorry, these are adaptive randomization. And one more technique is, sorry, I forgot to mention here, one more is stratified randomization. So stratified randomization, and this is adaptive way. So similar to block, you have stratified here, and adaptive randomization technique for prognostic factors will be covariate adaptive or minimization techniques. So these are the restricted type of randomization existing mainly to balance sample size between two groups or prognostic factors between two groups. So these are the basic methods of randomization. I will cover in detail simple randomization, block, and stratified randomization. These three I will cover subsequently. Rest of them I'll give you the principle. So simple randomization is a simple and elegant way of generating a random sequence. It is akin to what you do, throwing, dice or tossing a coin, and if your head comes, you assign treatment A. If the tail comes, you assign treatment B. So you already have an allocation rule. Whenever every time a participant enters your office, you just toss a coin. Whenever it lands on A, you assign treatment A, and whenever you get toss a coin, you get a tail, you assign treatment B. So this is as simple as you can do it. There is a complete, this is in a sense a true randomization where all the participants have equal chance of getting into either of the arm. So it's complete unpredictability of each intervention assignment occurs. So how you do? So the easiest way is tossing a coin, but mostly we won't follow this. Mainly, as you all know, when you do regulated trials, you have to have an audit trail. How you achieved randomization in reporting, also in peer review, how people will ask to see the integrity. So tossing a coin, it is very difficult to maintain an audit trail. So you always opt for either random number tables, and now we have sophisticated algorithm developed for computer generated random numbers that will give you throughout sequence. So that will give you sequence. Let us see how you do this by an example. So I have just copy pasted a random number table. So we have a 30 rows and 30 columns of random numbers, random numbers, which varies from 0 to 9, some random order. So you have a total sample size of, just imagine you have a sample size of n is equal to 10, and you have two groups, A and B. Intervention is A, control is B. So you simply allot a digit 0 to 4. If the number falls on 0 to 4, you assign them as group A, and if the digit follows 5 to 9. So this rule is totally up to you. The investigated team or the statistician who's involved in the trial decides this. You agree upon an allocation rule and you generate a sequence with the help of random number tables. So how to use a random number table? There is no hard and fast rule. You can start at any random place, go in one pre-decided direction to either right towards your right or go below. It's up to you. You can choose either way. You go in a pre-decided direction, you start at a random place, go in a pre-decided direction, and record one single digit number for each study participants. That's why the participant enrollment number is very, very important. So ultimately, the randomization worksheet will resemble like this. So you have the trial number, participant number, and you have the random number that has been appearing in the, noted down from the random number table you have appeared. And how will you allocate? See, so we have already decided anything from 5 to 9. Yeah, 5 to 9 will be treatment B. So anything from 0 to 4, I will label it as A. Thus, you have no control over the selection of participants. You just list out the numbers and you have allocation sequence ready at your hand with the use of random number tables. So nowadays we have softwares to do for that. You give the total sample size required, number of treatment terms, and what type of randomization, whether it is simple, block, or stratified. You say that, and the software will give you this. This is what is going behind the scenes. I just wanted to show you. Nowadays, previously, random number tables were commonly used to generate an allocation sequence. Now we have plenty of computer algorithms that can do for you. So it is a very, very simple, elegant design, but what is the problem with the simple randomization? When you have a very small sample size, so the probability of unequal group allocation, can you see here? When you have only n is equal to 10, the probability of getting A versus B is grossly not matched or not balanced. So here it is 2:8 and high probability, around 99% probability that you might get such kind of imbalances between A versus B. Then the purpose of randomization is not achieved, right? So, but when you go beyond sample size of 200, this imbalance becomes immaterial. When you have several thousands, this imbalance is found to be very small. So this is the disadvantage with simple randomization, I would say, because there can be disparate sample sizes in the groups by chance alone. So previously, a simple technique was used, that is replacement randomization. So you have a set criteria. Whenever there is imbalance, let's say, for example, I have a total sample size of 100, 50 in each group. I want 50 in each group. I do a simple randomization and get around 30 in one group and 80 in another group, 70 in another group, 30 and 70. So it is a gross mismatch between group A and B. So you have a predetermined size. So if the imbalance is 5 or more than 10 or more than 20, I will generate the sequence again till I achieve equal number or acceptable imbalance, that is less than 5 or less than 10. You pre-decide beforehand, and then you can do something called as replacement randomization. You will do the same procedure until you get equal number of participants or manageable imbalance in both the groups. So that is called replacement randomization. But now we have a better tool how to overcome imbalance in the sample size, mainly in small sample size. In academic trials, when we will have very small sample size, especially for MD thesis and all. When we design, it will be a single center study with small sample size. We all will land up with this imbalance problem. So the elegant way of addressing this will be a technique called block randomization. So here, your total sample size will be divided into blocks, wherein the treatment allocations are equal. So it is better explained with an example rather than telling the theory. So let's see another example where your total sample size is n is equal to 40 and you have two treatments A and B, similar to intervention and control. So I want, see, if n is equal to 40, then I want 20 in each group. So this is my criteria. So what you can do is, with the block randomization, you can create blocks, 10 blocks of size 4, right? Similarly, as you can see in the figure, can with every block will have 2 equal treatment assignment. So as you can see here, each block will have 2 A's and 2 B's. Okay, so and these blocks will be on different permutations. It will not be following the same order how the AB appears. Can anybody guess what will be the problem with doing block randomization? Is it truly randomization or not? Will you consider this as true randomization? Truly random or not? Any answers in the chat box? Anybody? Okay. So similar way, I will suggest. So if a particular physician is very keen in getting a patient to the intervention group, he can intelligently guess at the end by after randomly assigning, if you know the block size. So if the already A is over, so he might, if there is some indication, he might easily predict whenever a block is going to be completed, the last block can be easily predicted by an intelligent physician or anybody in the clinical trial team. Whoever is in can be easily able to predict it. So there is a way to avoid this. How we can do it? You can vary the block size. Instead of taking equal size blocks, like block size of 4, what you can do is you can make it into block of 4 and block size of 6. Okay, two blocks of 4 and 2 blocks of 6 also will lead to the same thing. So the varying block sizes, and they will vary. So first time maybe block size of 6 and second time block size of 4. That is also randomly these blocks will appear. So in that case, the physician or the clinical trial team cannot guess what will be the last block treatment. So this is one way of addressing the issue. Okay, so instead of equal size, you can vary the block size of 4 and 6. So the block size is usually the multiples of treatment groups. So here we have treatment group is 2, A and B. So I have chosen multiples of 4. So if it is 3, then you will choose block size of 6 and 12. Okay, so in single center, you prefer a bigger block size. Basically, you won't keep a block size of 2. At least for 2 treatment groups, you will go for a block size of 4 rather than block size 2, where A, B, B, A will keep on coming. So instead of block size 2, you please keep a bigger block size. At least block size of 4 is the perfect way of doing this. Okay, so this is how block randomization is done. So the total sample size, whomever you want, you divide them into blocks, and under each block, there will be equal chance of assignment in the groups. So even you might argue that for larger clinical trials, you need not do this block randomization. Anyway, simple randomization also will yield you equal number of participants. But if you are going to plan an interim analysis, then you might land up in a problem. The same, if you have planned interim, we have 1,000 participants. every 20% enrollment, if you are planning to do an interim analysis, the imbalance might creep in. So better in that case, if you have a planned interim analysis twice or thrice, it is always good to do block randomization rather than simple randomization, even for larger sample size clinical trials. It is, and block randomization is the solution for small, single center trials where the sample size is small, less than 200 or 100. So now we will move on to a type of biased coin randomization. Here, the allocation probability, in both these are variants. So biased coin and earn randomization is a variant of it. Here, what happens here? You are mildly altering the probability of choosing a particular assigning a particular intervention if there is an imbalance in the group size. So I'll just briefly tell you an example. I'm not going to tell you in detail. So as you all know, urn is a vase-like structure. Usually in ancient days, they used to keep elders' ashes. Okay, so this is the urn, and urn randomization is nothing but, so let's say for example, this yellow ball denotes treatment A and green balls denote treatment B. So you are just going to, if you get an yellow, you just take out a ball, and if you see an yellow ball, you assign the patient treatment A. If you take a green ball, you give the treatment B. So whenever you do this, what you will do, whenever you take out one ball, so the first assignment is truly unpredictable. You have equal chance of getting either a green ball or yellow ball. But here in the urn randomization, what they do, once an yellow ball is taken out first, for replacing it, you add one yellow ball as well as you will add one green ball. Okay. Now the probability changes. It is not 50-50% anymore, because there will be 2 balls of yellow, there will be 3 balls of green. So the probability tilts towards, the allocation probability tilts towards the next group. So it will keep on occurring. When you actually have equal sizes in both the groups, then the next assignment will be truly random. It is 50% chance either you pick up a yellow ball or green ball. But whenever the balance tilts, when you add the other ball, another ball, then you will take care of it. So in that way, when you do this, you will be able to achieve equal sample size in both the groups. So this is something called as adaptive way. So here, the probability of choosing a particular treatment changes as the trial progresses, because whenever when a participant gets an assignment, you add yellow ball or green ball accordingly. So you will add extra 1 ball of next color, which is not chosen in the previous trial. So that is the biased coin or earned randomization. Whoever is interested can, I have given the materials, you can go and read further. Okay. So now we will move on to stratified randomization. When we will do stratified randomization, I have already told in my classification, it is mainly to factor in the strong risk factors or confounders. If you want to balance the strong risk factors or confounders in both the groups, then you will go for stratified randomization. Like in case of breast cancer trial, if you already know, in the last session, the previous speaker has talked about the effect modifier. So if you already think a particular therapy will modify according to the subgroup of participants, and you want equal number of subgroups in both the treatment arms, then you go for stratified randomization. So main common prognostic factors which are commonly used for stratification are age, gender, disease severity or stage of the disease. And another important thing on which the stratification is done is by treatment center in case of multi-center trials, because usually if you see in large in NEGM Lancet large multi-center trials, they will always stratify by center type, because they are located in different geographic location. There might be difference with respect to the participants, the type and quality of given care available. And even if a particular center is not able to strictly adhere to the protocol or protocol deviation occurs, you can easily withdraw the center and still you do a very good analysis, easily analyzed. for these things in a multi-center trials, mostly the stratification is enabled through center is one of the stratification factor. So that's why it is commonly, if you can see in large trials, the center will be treated as one of the stratification factor. So here what they will do in stratification, I have given one example. So you have a total population of 1,000. Let's imagine age is your prognostic factor. You want equal age representation, both elderly as well as younger population. So the first thing you do is you do a strata. I mean, you divide your participants based on the age first. Okay. So age less than 60, 700. If age more than 60, if you have 300. Then the randomization, whatever technique, either block randomization or simple randomization is applied for each strata. The random sequence will be generated for this particular strata and this particular strata separately, so that equal number of, so in order to ensure equal number of sizes, you cannot go for simple randomization. In that case, you have to go for permuted block randomization, means the preferred method for stratifying. So once you achieve the strata, and then you subject for each strata, you generate a allocation sequence based on block randomization, so that you can achieve equal number in both the groups, okay, under each strata. So usually the stratified randomization, it is limited to 1 or 2 stratification factors. If there is multiple stratification factors, you cannot, purpose will be defeated. You cannot use this technique. In that case, you will do adaptive randomization. The procedure is called covariate adaptive, or your this minimization procedures. So they are akin to what we have seen, somewhat similar to what we have seen in the biased coin or urn randomization. There, the probability of an assignment to a treatment term varies based on their imbalance in the accrued population. For example, in the biased coin, as we have seen, if there is imbalance in the groups, then you add more ball in the other group, so that the next time the probability is 60% for that particular group to pick up. So similarly here, based on the prognostic factors, let's say for example, while the patients keep on accruing, you will note down how many are below 60, how many are above 60. Between the both arms, if this is tilted, then you will design, your computer will assign in such a way the group which has less representation will be having higher probability or altered probability, higher, either 60%, 75% probability of the next participant being assigned to the other arm. So that is what is about covariate adaptive or minimization technique, where multiple prognostic factors are balanced. So these are the techniques of randomization. So you can, for thesis purpose, we can very well use some online tools available, the randomizer.org and randomization.com. And otherwise, the randomization for regulatory trials, we have various statistical packages available. Because as I have said to you before, if you see ICH E9, the statistical principles, this randomization procedure is subject to auditing and it has to be reproducible. So the randomization seed number, they say, okay, so if you type the seed number, that is reproducible, the same randomization number will appear. Or in R and all, you have an audit proof. So which date, what you have generated, the sequence should be preserved for auditing, so that the randomization sequence generation is appropriate for the regulatory studies. And other data management systems like RedCap have the provision of doing randomization for you. You have to just choose for a given study design, which is the appropriate randomization method. You can, if you are novice, better it is better to discuss with the experienced clinical trial researcher or a statistician to get hold of it. So now we have finished only one step of randomization, that is how to generate a randomized sequence. So I have already told you randomization is not complete until and unless you do allocation concealment. So what it is, how we do this allocation concealment. So even just because you generated random sequence doesn't solve the purpose. You imagine a situation, you simply, so you can recall in simple randomization, I showed you a work list wherein the participant number 1 will be given A, participant number 2. The allocation sequence is already determined. You just paste it in your board or you hand over that sheet to the investigator. So, and you label the drug as A and B. You give drug A when the patient number is A, drug B, the patient number is B. So you can, even though you generate a random sequence, the purpose is not solved. If you if you conceal the allocation sequence. So how will you achieve it? Because still, if the prior knowledge of what sequences, prior knowledge of what the patient is going to get will again creep, the selection bias will creep in. The investigator or clinical trial teams can manipulate the allocation sequence according to their whims and fancies. So they have the known patient, they might prefer giving new drug, something like that can happen. Even after, they can delay the patient to come. You come after 2 days, so that if you know already the B is placebo, the one at hand is you already know the next patient is going to get B, and B is a placebo. If you know that, then the patient can easily, the trial team can easily manipulate. So you can ask the known patient to come later, so that they will get the treatment A. So such type of things are very found to be common in back in olden days. So what they have come out is this allocation concealment. This random, whatever sequence you have generated through one of the technique is being protected. This assignment sequence is not known to the investigator till a participant is assigned. Okay, so that is what this allocation concealment is about. So it is used to implement the generated sequence so far. So what are the methods which are commonly used? This sequentially numbered sealed opaque envelopes. It is also called as SNOS, S-N-O-S-E, sequentially numbered opaque sealed envelopes. So it is commonly acronymed as SNOS technique. So what they do, whatever sequence, now we saw a simple randomization, some 10 sequence are there. You write it in a card and put it in a sealed envelope. So there also multiple instances of some manipulation has occurred. So as you can see here in this figure, so when you put the envelope in a translucent cover, with the help of radiology, that radiology light box, you can easily decipher what is written over. So this is an exact depiction of how the SNOS is performed. So in order to avoid that, some techniques can be followed. You can use an aluminum foil wrapper, and whenever you are assigning a participant, the participant names, there should be a carbon paper placed inside the sheet, so that whenever you write the name of the participant in the outside of the cover, so it is impregnated in the B, which is inside the, so that should be kept along with your trial master file or your individual patient file. It has to be preserved so that it serves as an audit trail for your monitoring team. So sequentially numbered sealed opaque envelopes are preferred in case of single center academic trials where investigator-initiated resources are very limited, unless it has to be honored properly. That's when the randomization is preserved. Then the another way is sequentially numbered containers, where you directly assign your A, B, whatever your drug bottles, there you sequentially number them, you assign them, and whenever a fresh patient comes, you open the first number, whatever is in the A or B, you give the treatment to the assignment to the participant. And another way of doing allocation concealment is by central randomization, where there is a coordination office where you you give a call. You might be heard of these techniques, IVRS, interactive voice response system, or interactive web response system. Now many of us might be experiencing all this for a lot of utilities, for ordering food, etc., and for customer care. We all are used to this system. So similarly, a central coordination office will be handling your randomization list. So whenever you encounter a participant who is eligible, you have registered, enrolled, and the participant is eligible to get a treatment, you call the IVR system. It gives certain prompts. It will ask some questions, you put in, and it will tell you the allocation list. So the investigator will not have any idea of what this particular patient will be assigned. So that is the purpose of allocation concealment. So it can be done via a single multi-center trials. These are the preferred way of doing allocation concealment, and it has to be written properly in the paper as well. So as you can see here in this table. So you can, while writing minimally, at least you should write what is the method you followed for allocation concealment. Without this, your randomization procedure will be incomplete. Simply writing the random sequence generated by computer generated random numbers is not sufficient. You have to mention what is the allocation concealment method followed for your study. So for SNOWS, it is recommended you can add some few additional descriptions how we have taken steps to avoid manipulation, like the pressure sensitive carbon paper inside. So anybody has touched it or smudged it, it will be, so pressure sensitive or carbon paper inside the envelope transfers the information, and a cardboard or aluminum foil to maintain the opaqueness of the envelope. So in the numbered containers also, if the placebo versus active, there should not be, they should be equal in weight, and even through light, they should look similar in appearance. In pharmacy controlled, also, proper randomization will be retained with the pharmacy, and the researchers instructed the pharmacy for proper allocation concealment. So these are the such type of additional details that can be written in your paper to enhance the validity of how you perform allocation concealment. Next, we will move on to the next procedure called blinding. Especially in trials, ophthalmology trials, where blinding is also commonly used. Sometimes people ask whether what is the right word to use, masking. So blinding or masking, but blinding is the conventional way people uses this procedure. Blinding is always confused with allocation concealment. So I once again reiterate, blinding is not equal synonymous to allocation concealment. So allocation concealment is a part of randomization procedures. How you will implement allocation sequence. Okay, the investigator should not know priorly who is going to get what assignment. So that is the reason for allocation concealment. Blinding is done usually to avoid, say, bias anywhere after the assignment. Okay. Being involved in a trial is known to affect the participants' response. Okay, especially, for example, I'll take this example. So how it will, so the bias, what bias it is taken care of is here is ascertainment bias. Okay, knowledge of being taking a novel therapy might give a false sense of betterment in a patient, or it can be vice versa. It can be either way. So standard of care might be better for some patients. So that will be reflected in their outcome and assessment. So, and also if the patient is very well aware he is on placebo, he might not want to continue in the trial. Okay, or he might additionally take some other I am involved, if he already knows he is enrolled in the placebo group, he might look for other alternate solutions. Okay, anyways, I'm in placebo group, this drug is not going to work, so can I take some other drug which may not. So this will, blinding ensures such type of biases that might occur during the conduct of the trial. Okay, so blinding ensures prevention of ascertainment bias. So this is on the patient side. What happens when investigator and team knows the assignment? If he knows a particular patient is on standard of care or novel therapy or placebo, his outcome, his interaction with the participant might vary. If the patient is on placebo group, he might treat them or him or her differently, or if he has an dose modification might happen accordingly. So these are all the things that can change when a investigator and his team is aware of the treatment assignment, whether the patient is getting. And similarly, outcome assessor, let's say, for example, especially for subjective outcomes like pain scale, visual analog scale for some pain. So in those cases, or another important example is psychiatric diseases. Okay, so there and all, the outcome assessor should also be blinded. Otherwise, that might influence his interviewing technique. Okay, if he knows that some novel therapy is given, he might take more time to interview the patient to bring out all positive points, and vice versa, he might not give considerable time to placebo or standard of care patient. So all this, and a data analyst also might tweak the analysis or outliers they may handle differently if they have the knowledge of which group is given. So technically, in a trial team, participants, investigators and his team, outcome assessor and data analyst, if they have the prior knowledge of what assignment they are taking, that might influence the trial outcome. So finally, hampering the results of your trial, you cannot validly conclude. Your internal validity of the trial will be lost if such biases, ascertainment biases, creep into your study design. So this has to be carefully taken care of by blinding the study. So how will you achieve blinding? By just a second, by using a matching placebo. And again, depending on who are blinded, you often can see it is a single blind trial, double blind trial, triple blind trial, or quadruple blind. So since we saw single blind usually refers to patient alone being blinded, double blind usually refers to patients and investigators are blinded. So even if the patient and investigator is blinded, but if the outcome assessor of some outcome is not blinded, then the purpose is defeated. So nowadays, the common practice is instead of naming single blind, double blind, triple blind, you better mention who are all blinded in your study design. So the readers will take a approach whether to believe your results or not. So readers will decide for themselves. So you just mention who are all blinded in your study designs. So care should be taken care of carefully while designing where and all the bias might occur when measuring your outcome. So in some articles, they tell it as measurement bias also, but it is properly called as ascertainment bias. Knowledge of being in a particular trial might influence different stakeholders in different ways. So that will affect the outcome of the results. Either patient, if the that will make the outcome. Okay, that's all. So that is about blinding. So usually blinding is done with the help of matching placebo. So you try to get, if it is a capsule or a drug tablet, you try to get a similar matching, which is similar in appearance. Matching placebo is an inert substance. I'm not going to cover in detail, but I hope all of you have some idea of what is placebo is. It is an inert substance that is made to mimic, mostly made of lactose or starch, made to mimic the active ingredient in your treatment term. Okay, so how will you achieve blinding when you have different treatment schedules? If you have one single capsule, then there is no problem, but you have different treatment schedules. One drug should be given once daily and the other comparator should be given twice daily. So how are you going to account for that? And if it is of different formulation, drug A as an injection, drug B is a nebulization, or oral, any other route, if the route of administration or formulation varies, then how are you accounting for that? So you'll have two matching placebos, one for this formulation and one for this formulation. So this will increase the complexity of the trial. It's also called as double dummy technique, double dummy. But still, blinding is achieved. But whereas in case of some procedures like surgery, radiotherapy, it may not be feasible. That time you may have to design your study as open label trial. Okay, open label trial. And surgery, you would have heard of some sham surgeries are being taken. The patient will undergo anesthetize everything and only the closing procedure. So that is sham surgery, but that is considered to be unethical. Very few trials happens with sham surgeries as control. Okay, so mostly they happen to be of open label. So this is how blinding is achieved. So blinding prevents ascertainment bias. So coming to our last few slides, how will you report? As you all know, clinical trials are reported by consolidated standards for reporting trials. Consort checklist. You have a flow diagram where the patient flow diagram you give, and in the method section there is a dedicated randomization and blinding section. It's a 25 item checklist. So items 8 to 10 deals with randomization procedures, and item level 11 deals with blinding procedure. Okay, so as you can see here, so the sequence generation, what is the method exactly used? Is it a computer generated or which software used, you tell? And what is the type of randomization? Okay, if it is a restricted randomization, you tell exactly what is the blocking technique you use and what is the block size of that you have to elaborate. And the allocation concealment mechanism. So you have to elaborate what is the mechanism you used. And as I have shown you in the previous figure, you have to describe the steps as well, how additional steps are taken to conceal the sequence. Okay, if it is a SNOWS technique, have you had that, how you made it more opaque, how you made it more accountable with the help of carbon paper, that and all has to be elaborated. Similarly, in the implementation, so who actually done it? For example, who generated the allocation sequence? So most of the papers you can see the allocation sequence generated by the trial statistician, who has no role in the participants enrollment. So they specifically mention who actually generated the sequence. So where was it, whether the central pharmacy was involved, and who was who enrolled the participants. So the idea is the patients or the team who enrolls participants should not know the sequence in advance. So that has to be clearly brought out in your methods section. Similarly, for blinding, there's a 11th item is blinding, which is A and B. So if blinding is done, you have to tell who are actually blinded and how you have achieved the similarity of intervention. So is there any, what are the ways you achieved the similarity? So what is the matching placebo you used? How you obtained the matching placebo or matching capsule, etc., has to be elaborated in detail. So this is about reporting. So in summary, when you randomization and blinding are the two life and soul of RCT. That's why RCT is considered as the gold standard for establishing the efficacy of a drug. And the methodological excellence of RCTs are achieved because of these two procedures, randomization and blinding, since they eliminate all the important biases that happens in clinical research, which are seen with observational studies. Okay, and we briefly saw the methods of randomization. So simple and restricted. Here it's block and bias for balance to achieve imbalance in sample size. We saw the block randomization, and the adaptive type is bias to coin our own. In prognostic factors, we saw stratified, and these are the two adaptive randomization techniques. So these are methods of randomization we saw. Thank you. So if you have any doubts or queries, kindly put in the chat box, we can discuss.
Thank you, ma'am, for such a resourceful presentation. Now we'll take up some questions from participants. First question is, can the block selection can itself have selection bias?
Sorry, I'm not able to.
Ma'am, this is a question from chat box. Can the block selection can itself have selection bias?
Block selection itself cannot have selection bias. Yeah, only thing is in a particular block, the last assignment can be easily predicted from the physician if they closely follow the assignment. The same physician is involved, then they can predict. So usually it is recommended to vary the block size. And again, if you properly follow allocation concealment, you will not know what was the block size, what is the first block allotted, that you will not know if you properly follow allocation concealment. Okay.
And second question is, can stratified randomization applied if we do not have pre-specified population from which sample is drawn?
Okay. No, see, for stratification, you have to already know from the literature what is the prognostic factor that you are looking for. Otherwise, you can, if it is a large trial, simple randomization will take care of balancing your known and unknown risk factors. Is it clear? So for stratification to happen, you should priorly know the strata. So for your central randomization team, will have two different sequence for two different strata. Let's say, for example, for age, you have two strata. So you have to tell the randomization team or allocation team, you have to tell your age of the patient is below 60 in that example which I have shown. Then accordingly, what is the treatment assignment that will be given? So it cannot be, you should know beforehand the pre-specified population. And what is the exact prognostic factor you are looking for? So how many stratas you have in hand? And for each strata, you should have a randomization sequence. So then only you can do it.
Thank you, ma'am.